Thanks so much for the introduction. It's great to be here with all of you to discuss neuroendocrine tumors. Looks like we have the slides loaded. So these are cancers that are different in many cases compared to other types of cancers that you may be more familiar with seeing. So there are unique aspects in terms of diagnosis and treatment, and also prognosis. So for example, not all metastatic neuroendocrine tumors are the same. You may have someone who has a metastatic neuroendocrine cancer that unfortunately only survives for a couple months after diagnosis, versus you may have another patient with a neuroendocrine cancer that has metastatic disease and lives for decades on a once-a-month injection that causes few, if any, side effects. So it's important to understand the heterogeneity of these tumor types. Dr. Liu nicely outlined the history of cancer over a long period of time. I'll focus on a shorter period of time over the last couple decades, but you'll see that there have also been a lot of advances with these types of treatments, which ultimately help our patients. And one of the types of targeted therapies that we will talk about is actually a targeted therapy that delivers radiation specifically to these tumors via an IV injection. All right, so we'll start with background and then talk about diagnosis and treatment. The majority of the talk will be focused on neuroendocrine tumors, which are well differentiated and have a better prognosis. And then we'll say a few words as well about neuroendocrine carcinomas, which are more aggressive. So these are some common assumptions about cancer. The incidence of most cancers is decreasing. The most common presenting symptom of cancer is pain or weight loss. When cancer has spread to other parts of the body, survival is very short. And treatment for metastatic cancer is primarily chemotherapy, and this is hard to tolerate. It's toxic, and it doesn't work very well. It turns out that all of these may be incorrect when it comes to neuroendocrine cancers. So neuroendocrine cancers were historically referred to as carcinoids, which means carcinoid-like. So Dr. Liu talked about the origin of the word carcinoid, and these are carcinoid-like tumors, carcinoma-like tumors. In today's nomenclature, these are better referred to in most cases as a neuroendocrine tumor, and the term carcinoid is reserved for symptoms associated with these tumors that can occur due to hormone hypersecretion. This is in contrast to neuroendocrine carcinomas, which are much more aggressive. These are poorly differentiated and have a much shorter survival overall. So neuroendocrine tumors, again, are well differentiated and then are further divided by tumor grade, which I'll show you in a moment. Grade 1, grade 2, grade 3. So grade 1 is typically the least aggressive, best prognosis. Grade 3 is more aggressive, and even more aggressive is the poorly differentiated neuroendocrine carcinoma. So these are a distinct group of tumors that can arise from neuroendocrine cells anywhere in the body. These can arise in the pancreas, these can arise in the small bowel, these can arise in the colon, the rectum, the lungs, etc. Really anywhere in the body, these can arise. And these tumors are characterized by their ability to secrete hormones. So these can be things like serotonin, histamine, gastrin, insulin, glucagon, etc. And symptoms associated with these tumors oftentimes depend on which hormone or hormones these tumors primarily secrete. Right? So if a tumor is secreting too much insulin, the patient will have low blood sugar. If the tumor is secreting too much gastrin, the patient will have trouble with significant and severe gastric ulcers. So in addition to hormone secretion, these tumors can also present with tumor growth, right? So local symptoms related to an enlarging mass, or sometimes can even be asymptomatic and can just be incidentally discovered via imaging that was done for a different reason. In terms of functional versus non-functional neuroendocrine tumors, that depends on how much hormone the tumor is secreting. So most of these tumors will secrete some level of hormone, but it's not necessarily enough to generate symptoms. And in that case, these are termed non-functional neuroendocrine tumors. Tumors that secrete more hormone that causes symptoms, for example, histamine-related, like flushing, diarrhea, wheezing, are referred to as functional neuroendocrine tumors. The GI tract is the most common site of neuroendocrine tumors, as you can see here, but the lungs make up about a quarter of the cases. And within the GI tract, these can occur anywhere, small intestine, colon, rectum being quite common. The incidence of neuroendocrine tumors is increasing. So this slide shows an increasing incidence of a variety of locations of neuroendocrine tumor, lung, stomach, small intestine, et cetera. And you can see since 1973, all of these locations are increasing. And in fact, there's about a 5-fold increase in the past 30 years. It turns out that this incidence of NETs is rising faster than any other cancer type. So NETs is shown in orange, and the blue line is all other cancer types. And you can see a stark contrast between NETs and everything else. This may be due to increasing technology to better identify neuroendocrine tumors either earlier and or more sensitively. What are the risk factors for neuroendocrine tumors? These include things like family history and inherited syndromes, for example, multiple endocrine neoplasia, von Hippel-Lindau syndrome. Most patients with a hereditary syndrome will present earlier in life with neuroendocrine tumors, for example, in the pancreas, sometimes with other associated tumors as well. These cancers are more common in white people. Chronic inflammation also predisposes. So for example, pernicious anemia with gastric inflammation or chronic pancreatitis are risk factors, as is smoking. So we'll next turn our attention to diagnosis. So neuroendocrine tumors are like zebras. If you don't suspect it, you cannot diagnose it. So you have to keep these tumors in mind on a differential diagnosis. As you'll see in a moment, symptoms associated with a neuroendocrine tumor are quite nonspecific, and these tumors can be quite hard to diagnose. Because of that, a systematic approach is really necessary for approaching a possible neuroendocrine tumor. This includes a detailed history and exam, so symptoms like flushing, diarrhea, cramping, wheezing. Blood tests and urine tests, which are specific for neuroendocrine tumors, like chromogranin and gastrin, which you won't pick up on routine blood counts or metabolic panel. Imaging, some of which are pretty standard, like a CT scan, but some are not, like a PET scan with dotatate technology, as well as endoscopic ultrasound, and we'll look at each of these in more detail. The estimated time on average for diagnosis of a neuroendocrine tumor from initial symptom onset to diagnosis is 3 to 7 years, which is a very long time when it comes to cancer. For example, a patient may come into their primary care doctor with vague abdominal symptoms. That leads to an initial workup, then referral to multiple specialists, and finally, after multiple years and lots of tests and frustration, a biopsy is done, which confirms the diagnosis, and then the patient would meet with one of us to talk about next steps, and then meet you all potentially for the treatment. So the carcinoid syndrome, which relates to hormone hypersecretion, occurs in about 1/3 of patients with neuroendocrine tumors. And usually, in order for these symptoms to develop, there has to be tumor that has metastasized to the liver due to metabolism of these hormones in the liver if they're going through the portal circulation, for example, from the gut into the liver. This is a consequence of vasoactive peptides, as I mentioned, like serotonin and histamine, and the common symptoms include flushing, wheezing, diarrhea, and as well as potentially heart disease. Heart disease is usually on the right side, so the right heart valves, and that's because as these hormones then go from the right heart to the left heart, they have to pass through the lungs, which actually metabolizes the hormones such that you're not getting impact on the left heart. So these symptoms, as you're gathering, are nonspecific and generalized, right? Flushing, diarrhea, skin issues, abdominal pain, wheezing. And these fall into many different possible diagnoses. So neuroendocrine tumor is one of the diagnoses that can account for these symptoms, but I'm sure you all can think of many other conditions, right? Most of which are not cancer, that can cause these symptoms. Asthma, anxiety, stomach ulcers, IBS, food allergies, et cetera. And these are just a few examples. The list goes on and on. So this contributes to the delay in diagnosis. Biomarkers are specific to neuroendocrine tumors. So some of them are usually produced by most neuroendocrine tumors, like chromogranin A. Some are more specific to the tumor type. So for example, stomach neuroendocrine tumors can make gastrin, and pancreas neuroendocrine tumors can make insulin, glucagon, VIP. And again, the type of hormone that is produced will dictate the symptoms. However, these biomarkers are not perfect, and there can be false positives and false negatives. For example, with urine 5-HIAA, there are many foods or medications that can result in a false positive. So it can be hard to use this when trying to make a definitive diagnosis. Chromogranin A is also commonly checked in clinic, but these are falsely elevated with things like proton pump inhibitors, which probably many people in this room take and millions of people take across the country. So imaging. So CT scan, you're all familiar with, right? And this allows us to see masses. A standard CT scan does not have contrast. We call it a CT scan without contrast, which is shown in the upper left here. And in the circled area, you see no abnormalities in that region. However, when you do multiple phases of IV contrast with arterial, kind of on the upper right, you see the spot, the mass light up. And then on the delayed phase, which means waiting a few minutes after the contrast is given, it washes out. So you see that rim of contrast enhancement on the outside, but nothing on the inside. That is a characteristic of neuroendocrine tumors, so multi-phase contrast imaging is necessary to see these, which may not be routinely ordered. The reason we see these well with multi-phase imaging is these tumors have a lot of blood flow, and so you get a lot of uptake of the contrast into the tumors. There's also a more specialized way that we can visualize these tumors on a scan. So neuroendocrine tumors express something called a somatostatin receptor, which is quite critical to both the diagnosis and the treatment. Okay, so you see here, neuroendocrine tumor has this little receptor on it, which is different than a normal cell. And again, this is called the somatostatin receptor. So what we can do to visualize these tumors is actually give a type of contrast that binds to this somatostatin receptor and is linked to a radioactive tracer. That tracer will then bind to neuroendocrine tumor cells in the body and not bind to normal cells. And that can allow us to visualize these as they light up. So on the upper left, you see a CT scan of the pelvis that shows no masses. On the bottom left, with a PET dotatate scan, the two circled areas are lighting up yellow, which indicates neuroendocrine tumor. In the middle, we see two types of imaging. One is the dotatate scan, which is on the right, similar images to what we just looked at, but for the whole body. And you can see that there's very high resolution throughout the body to visualize these masses. Previously, we used something called a somatostatin receptor scintigraphy scan, which is shown in A, also called the Octria scan. And those images are much more blurry than with the more modern dotatate imaging. So the standard of care approach when trying to diagnose a neuroendocrine tumor is to obtain a dotatate scan, which is in many cases better than what we will see with CT or MRI. It's important to note that a dotatate PET scan is different than an FDG PET scan. So when most people talk about PET scans when it comes to cancer, they're talking about an FDG PET scan, which uses a sugar tracer, which is good for most other cancer types, but usually not good for neuroendocrine tumors. So not all PET scans are created equally. The only exception to this is for a high-grade neuroendocrine carcinoma, again, poorly differentiated, behaves like a small cell lung cancer, an FDG PET scan rather than a dotatate is what we want to use. Endoscopic ultrasound can allow us to obtain biopsies from difficult to reach locations. So think about this like an upper endoscopy. Instead of just having a camera on the end, there's an ultrasound probe on the end. We can use that to visualize tumors and then use a small needle to take a biopsy to confirm the diagnosis. Once we have that tissue, the pathologist examines it and classifies it per the World Health Organization system here. So well-differentiated tumors are broken up into grade 1, grade 2, grade 3, like we looked at. Grade 1 is more indolent, as is grade 2. Grade 3 is kind of intermediate in aggressiveness. And then the most aggressive is that poorly differentiated neuroendocrine carcinoma. And we use a marker called Ki67, which is a stain that the pathologists look at to help assess the aggressiveness. The higher the number, the more aggressive. So in the last 5 minutes here, we will talk about treatments. So what determines the treatment plan? And this is accurate for many different types of cancers, not just neuroendocrine tumors. Stage of disease, is it localized or metastatic? What's the tumor grade? How aggressive is it? How many symptoms does the patient have? What sort of other medical problems, comorbidities, functional status does the patient have? All of which will help formulate the treatment plan. Fortunately, we've developed a lot of new treatments for neuroendocrine tumors, and prognosis is much better than it used to be. So there's a lot of tools in the toolbox for treatment of these cancers. Some patients may actually be appropriate for watchful waiting, which may sound surprising that we're suggesting doing nothing actively to treat a cancer, right? But this actually may be appropriate for small tumors that are asymptomatic and may grow at a rate of just a few millimeters per year. If a tumor is localized, it can often be removed surgically or endoscopically. If a tumor has spread to a limited number of locations in the liver, we may be able to do liver surgery, embolization, ablation. We also have many systemic therapy approaches, which we'll go into detail here. Somatostatin analogs like octreotide or lanreotide, okay? Peptide receptor radionuclide therapy, which is that IV targeted radiation therapy, and other targeted agents, and finally chemotherapy. However, we very rarely have to use chemotherapy for these tumors. So we're now back to the somatostatin receptor, which is the critical piece of treatment for these tumors. As we looked at, somatostatin receptors are overexpressed on neuroendocrine tumor cells, and we can also exploit that not only for imaging, but also for treatment. So in general, how do we treat a well-differentiated grade 1 tumor? First of all, is observation an option? If no, is surgery or ablation an option? And again, this is appropriate for folks who have a lower burden overall of tumors. If not, we usually start a somatostatin analog, which are drugs like octreotide or lanreotide that many of you have probably given in your clinics or infusion centers. If that doesn't work, we switch to something called PRRT, peptide receptor radionuclide therapy. And if that doesn't work, we come to those other targeted or chemotherapy options. So lanreotide and octreotide are somatostatin receptor analogs. These just bind to that same somatostatin receptor that we've been following and shut down signaling pathways, which ultimately decrease tumor growth and decrease production of hormones that cause symptoms. These are the two clinical trials that led to the approval of these drugs called PROMED and Clarinet. The top line in both is with the drug. The bottom line is with placebo. And you can see that on average, progression-free survival, meaning time until the tumor starts growing, is significantly better with both of these compared to nothing. And fortunately, both of these treatments are well tolerated for the vast majority of people. Peptide receptor radionuclide therapy is kind of the cool treatment when it comes to neuroendocrine tumors. And how this works is we're targeting that same somatostatin receptor. This time, instead of just having a somatostatin analog that binds to the receptor, it's linked microscopically to radiation. So this is given IV once every 2 months. It targets specifically to the neuroendocrine tumor cells, gets uptaken into the cell, and then the radiation damages the DNA to kill the tumor. 4 total treatments, 2 months apart, and on average it works for more than 2 years, which is shown here. So this is a very appealing option for patients, and again, we typically use this after the somatostatin analogs stop working. Poorly differentiated neuroendocrine carcinoma is totally different. Think about this like a small cell lung cancer. It's very aggressive. It's almost always metastatic. For these sorts of tumors, we need chemotherapy like a platinum and etoposide. And in the metastatic setting, survival is unfortunately quite short, on average 1 year or less. So these are my last couple slides here. Patients with neuroendocrine tumors need a multidisciplinary team, which is something that we feel very strongly about. In the last 20 minutes, we've talked about all of the folks listed here on the slide, right? Surgical oncology, nuclear medicine, interventional radiology, medical oncology, gastroenterology, and I think outcomes are the best when we have all of these specialized services available. So in conclusion, these tumors can occur anywhere in the body. They can have carcinoid syndrome, most commonly diarrhea, flushing, wheezing. These are hard to diagnose. You need to keep in mind specialized testing, whether that's blood tests or imaging, that are not done for most other cancer types. The prognosis is highly variable, and treatment continues to get better and better. Most of the treatments are quite targeted, focusing on that somatostatin receptor, and only rarely do we need to use chemotherapy. So thank you very much.